Thank you. So we looked at patient satisfaction with a new enhanced recovery programme for our thoracic patients. Just for those that aren't sure what enhanced recovery is, a wee bit of history about it. It was developed by Henrik Kellick in Denmark for colorectal patients, and they looked at how they could improve things for the pathway, speed things up for patients, try to reduce how far we take them away from what's normal for them, reducing their stress response to surgery and improving the recovery time. And a key part of that was patients being active in their own recovery as well. And the success of enhanced recovery has been recognised in other surgical fields, and it's been adapted in other surgeries, and thoracic is one of those. So the enhanced recovery principles are trying to get patients fit before surgery, both mentally and physically, so that they can manage their expectations, they know what the journey is going to look like, so they're fully engaged, as well as trying to optimise them physically so they have better outcomes post-op. Looking at what we're doing to them intraoperatively and giving them the best possible management and ensuring they get the best possible recovery. The key points are that the patient has to be actively involved. It involves the full team from referral to discharge, and the hope is that that would improve patient outcomes. It's not exactly rocket science, but it's really standardising exactly what we're doing for patients to give them the best possible care at each stage. So our study looked at what patients thought of the Thoracic Enhanced Recovery Programme and if there was any specific parts that we could improve upon. The population that we looked at was a post-op lung resection patients. It was a quantitative descriptive design. We used a questionnaire which we adapted from a national tool, and we analysed it using SPSS. Just to give you a brief overview of what the programme looked like, it goes from referral right through to discharge. At the referral stage, we want to make sure that patients are fully educated, that they're on board, their expectations are managed for what they need to do to recover and to try and get a bit fitter for coming in for surgery, and making sure that they can make an informed decision about what's happening along the pathway. This is still an evolution, so the prehabilitation part would be evolved and added into the pathway in the future. Pre-operatively, ensuring that what was started at the referral stage continues, engaging with the patient, ensuring that they understand what will be happening with them, picking anything up at pre-op assessment that needs to be optimised, and at that point starting discharge planning so that the transition from hospital to home is as seamless for the patients. One thing that we did look at that is recommended in enhanced recovery is carb loading. It made more sense to do it in the colorectal cohort of patients, but we didn't find any strong evidence to do it for the thoracic patients. So we haven't included that in our enhanced recovery programme. But we did look at minimising the amount of time that we fasted patients, especially from fluid. Intraoperatively, we have moved to predominantly VATS surgeries. Over 65% of patients now will have surgery as a VATS procedure. We've standardised our pain pathway to predominantly paravertebral blocks, using less drip strains and catheters, trying to take the patient away from what's normal for them to minimise that impact. And post-operatively, trying to get them back to what's normal for them as soon as, getting them up and actively mobilising them on theatre a day if we can, reducing the amount of fluids that we're using, actively managing their nausea, and continuing on that discharge planning, because things can change from what's happened at pre-op. So we want to make sure that that's seamless for patients going home. So we adapted a questionnaire with permission from the Care Quality Commission. We wanted to keep it nice and short. We didn't want to overwhelm patients, so we kept it short to 17 questions. We gave that out to patients just before they went home, to all our lung resection patients, but we did exclude the ones that deviated from the enhanced recovery pathway, and those patients who ended up with post-op delirium or cognitive impairment. We had 110 patients who we potentially could answer, and 47% did. We gave us a 43% return rate. It was fairly even split between genders, and age ranges 42.5% were under 65 and 57.5% were over 65. Overwhelmingly, the results were quite positive. Patients were quite happy with the pathway. Just a few areas that we found didn't score as well, which gave us pointers to improve, which I'll talk about a wee bit later. But 94% of the patients thought the pathway was excellent. We looked at age as well, because we scored quite highly in a lot of things. We wanted to look a wee bit more deeply to see if we could find any links in younger and older patients. What both cohorts stayed a similar amount of time, so it was they experienced a similar pathway, so we could look at what they thought. There was no significant difference in their overall satisfaction between under 65s and over 65s. One area that we did find could be improved upon was booklet engagement. That was a key part of the enhanced recovery pathway. We developed a booklet to educate the patients and take them through the journey. Although quite a high proportion found it useful, and we classed engagement as completing the day-to-day diary and following the day-to-day pathway. Quite a low percent actually completed it, which I suppose could be understandable if patients are a bit sore and they don't really want to be writing in diaries and things, but more of them did actually follow the pathway, which we're more concerned about. They actually engage in what we want to do, but that could have been better. We wanted to see if that was any different between the age ranges. And you can see the older patients were slightly less engaged with the booklet. The reasons for that weren't very clear. That's something that we might have to look into a bit more, but something that we can improve upon. Something else that didn't score quite as highly was patients' understanding of who they could contact after discharge. We thought that was quite important to understand because patients were going home sooner. Some patients who were having Uniportal were going home at post-op day 3, so we felt it was quite important that they understood what was their route to find out more information post-op should they need it. And that can be improved upon. And quite surprisingly, the younger patients, less of them knew who they wanted to contact post-op, but the older patients did know. The reasons aren't clear, but anecdotally you could maybe say that older patients have been in the health system a bit longer, they've maybe been in and out of hospital a bit longer, so they're maybe more comfortable with who they should be contacting. Obviously that's conjecture, we don't exactly know why that is. So overall, we found the patient satisfaction with the pathway was quite positive, and a couple of areas that we wanted to improve upon is patient engagement with the pathway and the booklet, and our communication with patients as well. But obviously it's a small sample size, so we would need to do a bit more with a larger sample size to make it significant and generalisable. And it would be worth repeating in the future with changes coming up in thoracic surgery, for example 3D VATs, changes in the approaches to surgery, increase in improvements in patient outcomes through prehabilitation, and dare we say it, one-day lobectomies. Thank you.